Welcome to the ups and downs of the neuroendocrine system. My name is Donna Avanecean, and I will be your presenter today. I'm currently an APRN in neuro-oncology at Hartford Healthcare Medical Group and the Cancer Institute at Hartford Healthcare. And I would like to thank you for joining today's session. This session will be offered in two parts. Part one will focus primarily on disorders of hormonal imbalance, and part two will focus on fluid and water balance issues. I have nothing to disclose. The objectives for today's session is to, one, identify the hormones secreted by the pituitary gland and their action, and two, describe the pathophysiology, management, treatment for patients with growth hormone deficiency, growth hormone excess, adrenal insufficiency, Cushing syndrome, and part two will focus on patients presenting with fluid water balance issues, including discussions on SIADH, cerebral salt wasting, and central diabetes insipidus. We'll begin today's session by a brief discussion regarding the anatomy and physiology of the pituitary gland. As you are aware, the pituitary gland is a pea-sized gland located in a protective bony enclosure called the sella turcica, which is located at the base of the skull. The pituitary gland is connected to the hypothalamus by the infundibulum, also known as the pituitary stalk, which allows communication between the pituitary gland and the hypothalamus. The pituitary gland is comprised of two lobes, an anterior lobe known as the adenohypophysis and a posterior lobe known as the neurohypophysis. So in this cross-sectional cartoon, you have a view of the pituitary gland sitting in the sella turcica. Here is the identified infundibulum, and then of course the hypothalamus. This is a cross-section of the same picture or cartoon. And again, you have your pituitary gland, you have your hypothalamus, and your infundibulum. In this more close-up examination, you have your anterior pituitary gland and the posterior pituitary gland. And here is another anatomical view of that from the dorsal view. And here is your pituitary gland. You have your optic nerves, your optic chiasm. Sella turcica is sitting just below. Now, the pituitary gland, more specifically the anterior lobe, contains 5 different types of cells which are responsible for specific hormone secretion. Somatotropes are responsible for the secretion of human growth hormone, which stimulates growth of bone, cartilage, and muscle. Corticotropes are responsible for the secretion of adrenocorticotropin, also known as ACTH, which stimulates glucocorticoids and mineralocorticoids and is responsible for androgen production by the adrenal cortex. Thyrotropes are responsible for secretion of thyroid-stimulating hormone, which stimulates the synthesis and secretion of thyroid hormones. Gonadotropes are responsible for gonadotropic hormone secretion, including luteinizing hormone and follicle-stimulating hormone, which are responsible for stimulating growth and maturity and are responsible for normal functioning of primary and secondary sex organs. And finally, lactotropes, which are responsible for secretion of prolactin, which is responsible for stimulation, the growth and formation of mammary tissue and promoting lactation. Now, the posterior lobe is directly, as I've stated before, connected to the hypothalamus through the pituitary stalk or infundibulum. The posterior lobe contains magnocellular neurosecretory cells that are synthesized by the hypothalamus and are actually stored and secreted by the posterior lobe. The two that that the posterior lobe are responsible for storing and secreting are the anterior antidiuretic hormone, ADH, and oxytocin. Antidiuretic hormone is also known as vasopressin and arginine vasopressin, and the majority of ADH is secreted in the hypothalamus and responsible for the reabsorption of water by the kidneys. Oxytocin is one of the few hormones that provides a feedback loop. So in this cartoon that I have shown you here is you have the infant or the fetus in utero as the baby is engaging into the birth canal. The head will push down upon the cervix. There are nerve impulses within the cervix that are transmitted to the brain. The brain in turn will stimulate the pituitary gland to secrete oxytocin. The oxytocin is then carried into the bloodstream to the uterus. And finally, the oxytocin will stimulate uterine contraction and push the fetus forward into the cervix. We'll begin today's lecture by discussing growth hormone deficiency in children, known as pituitary dwarfism, and growth hormone deficiency in adults. Growth hormone deficiency in the pediatric population is a result of underproduction of the growth of hormone, causing the child to have features that include short stature with normal body proportions, and is most characterized by decreased growth velocity and delayed skeletal maturity. It's a very rare disorder within the pediatric population that requires early recognition, diagnosis, and treatment in order to improve outcomes. The overall prevalence, though, is about 1 in 4,000 per 10,000 live births per year. When we look at etiological factors for growth hormone deficiency in the pediatric population, we can divide those into two: genetic. There have been mutations of the GH gene identified, and to date, there have been multiple ones that can be tested for. Some acquired etiological factors for growth hormone deficiency in the pediatric population include multiple mechanisms, including direct effect on the hypothalamus, tumors of the pituitary gland, and other CNS tumors, including germinomas, craniopharyngiomas, optic gliomas, head trauma, CNS infections, surgery, and vascular events. When children and their parents are presenting with possibility of growth hormone deficiencies, there may be complaints of headache. The parents may notice a decreased growth pattern, and the parent or child may even notice excessive thirst and urination. Objective findings include evidence on growth chart of a slow or absent growth or short stature, normal growth and development for the first 6 months of life. And then what happens is the child then is noted to have a growth deficit. There is evidence of the child falling below the 5th percentile on the growth chart. And if this goes unrecognized, there may be absent or delayed development of secondary sex development in adolescence. The cephalofacial features are very specific in growth hormone deficiency, and these children have the appearance of a baby face. In fact, when you look at children who have growth hormone deficiencies, the upper to lower body ratio is greater than normal, and it almost is similar to that of an infant. So we have some pictures here and a cartoon. Here's the child who has growth hormone deficiency compared to a child of normal age, or same age, excuse me. And in the picture here are some of the classical features that you would see in a child who has growth hormone deficiencies. Diagnostic workup is a multi-step process that includes both physical examination, biochemical testing, and radiological imaging. You want to start off with a complete history and physical examination, including the mother's pregnancy history, the birthing history, and growth and development as regards to achieving milestones and at what age. You want to arrange for radiological imaging, including plain X-ray of the extremities to determine bone age. You may need to use a dual energy X-ray, also known as a DEXA scan, in determining the bone age. CT and MRI imaging of the brain to rule out any evidence of structural causes for growth hormone deficiency. And a skull X-ray may help in aiding in the diagnosis if you see any erosion of the sella turcica that may indicate the growth of a pituitary tumor. Now, as far as laboratory testing, you're going to want to order some thyroid function testing to rule out thyroid disease as a cause of symptoms, CMP, CBC. You want to do a celiac screen, inflammatory markers to rule out any other causes of the symptoms that the child is presenting with. For growth hormone stimulation, you can use a glucagon test and an arginine stimulation test. You're going to also want to do or perform direct measurement of IGF-1 and IGFP3. And finally, if you feel or there is a belief that there may be a genetic etiological reason for the growth hormone deficiency in this population, then you're going to want to arrange for a genetic testing to be performed to identify if there's any mutations present. Management, you're going to want to refer the child out to a pediatric endocrinologist, but at each encounter, measure and document the height and weight. And of course, you want to compare that to standardized growth chart. And of course, at the age appropriate time, start to assess for the development of secondary sex characteristics. Interventions, you're going to replenish the growth hormone by recombinant GH replacement therapy. The initial growth hormone dose is 0.16 to 0.24 milligrams per kilogram per week. In divided doses, that's at 22 to 35 micrograms per kilogram per day, with individualization on subsequent dosing, and usually it is based on repeat serum evaluation. The recombinant GH replacement therapy can be given either through IM or sub-Q injection. Patient education and anticipatory guidance. Of course, you're going to want to provide in-depth patient education regarding the disease, the nature of its illness, the importance of adhering to the replacement therapy, as well as the need for reevaluation with serum labs, and of course, potential side effects of the replacement growth hormone therapy. Now, as we shift our discussion to growth hormone deficiency in adults, it occurs as a direct result of, again, insufficient production of growth hormone in the anterior pituitary lobe. In the population, there are about 6,000 new cases per year of newly diagnosed growth hormone deficiency in adults. 15 to 20% of those cases are attributed to childhood growth hormone deficiency. The estimated prevalence is about 1 in 10,000 in the population, and individuals receiving cranial radiation, the prevalence can be as high as 45%. Etiology, in 15 to 20% of adults with growth hormone deficiency, this is a continuation from childhood. And as with the pediatric population, there may be genetic mutations that are the cause of the growth hormone deficiency. Acquired causes include the development of tumors within the hypothalamus or the pituitary gland, including pituitary adenoma, Rathke's cliff cysts, craniopharyngiomas, gliomas, germinoma, and metastatic tumors, including breast, lung, colon, and prostate. It also, as I've already stated, may be a direct result of cranial radiation. Neurosurgical interventions involving the pituitary gland and the hypothalamus may result in growth hormone deficiency. Cranial trauma, including head injury, vascular events, including stroke and subarachnoid hemorrhage, as well as infections involving the central nervous system. Other acquired causes include infiltrative and granulomatous diseases, such as in sarcoidosis and even tuberculosis. Data assessment. Patients who have growth hormone deficiency may complain of low energy, malaise, depressed mood. They may have difficulty with functioning at work because of decreased concentration and memory, complain of difficulty sleeping, dry skin. Many of them may also be found to have sleep apnea. There's also associated weight gain despite calorie restriction, exercise intolerance, and even muscle weakness. Objective findings, there's usually impaired glucose tolerance. A lot of these patients on a lipid profile are found to have elevated triglyceride levels, low high density lipoprotein levels. You're going to want to know if there's any history of head injury, radiation, or stroke. There generally are short stature when compared to their family. There's usually increased body fat, most notable around the abdominal and central trunk regions, decreased lean body mass, decreased bone density. They may be also found to be hypertensive. And as I've mentioned, the skin is very dry and very, very thin. Diagnostic workup in the adult population is reserved for individuals who you feel there's a high probability of the disease. And again, not to go over the same information, but it's going to be in those patients with trauma, cranial RT, signs of pituitary dysfunction. It's usually diagnosed by provocative testing, such as insulin tolerance test, although I would recommend withholding this testing in the elderly patients and patients with known history of seizures and cardiac history. Serum insulin-like growth factor and radiological imaging, including MRI of the brain. Other lab work will include lipid profile, although this is not diagnostic, but may help in the diagnosis. And deficiency is usually frequently found. Most of these patients have the dyslipidemia that I just outlined. Medical treatment, growth hormone replacement with recombinant human growth hormone. The dosing recommendations are highly individualized, or they can be weight-based. The dosing is, though, based on sex, estrogen status, and age. In adults with diabetes, they may require medication dose adjustment of the diabetes medication, but the initial dosing can be anywhere from 0.1 to 0.2 milligrams sub-Q, and it's to be given in the evening time. You also want to give replacement therapy, which is titrated according to the individual's responses, meaning their repeat lab exams, side effects, and as I've mentioned, the IGF-1 levels. Women typically will require higher doses, and especially in those women who are taking estrogen therapy. Adults with diabetes mellitus, when you are titrating the dose of the growth hormone replacement, it is usually done at a slower titration. Patient education is going to be similar to that of the pediatric population in that you're going to want to educate the patients about their disease, the nature of their illness, the importance of taking their medications on time, proper administration, any adverse effects, and more importantly, the importance of medication adherence and reporting any side effects to the medication so that further titration may take place if they are experiencing intolerable side effects. And these patients should be treated also by a endocrinologist. Patient outcomes in children, of course, it's going to be adherence to hormone replacement therapy. You want to observe an accelerated growth velocity to promote normalization of growth in the first year of treatment. And what you should expect is about 4 to 6 inches in growth height within the first year. And of course, Another outcome would be that the child would grow to a normal adult height appropriate for their genetic potential, and that they would achieve increased bone mineral density and lean body mass and decreased fat mass. And in the adults, again, you want them to be adherent to their treatment plan, improve their body fat distribution and lean muscle mass, improve bone density, their cardiac function. And usually these patients, their quality of life will greatly improve. They'll have better exercise tolerance, decreased fatigue, improved memory, and overall better functioning and the ability to concentrate and function at work. That completes our discussion on growth hormone deficiency in both the pediatric and the adult population. I'd like to now shift our discussion to growth hormone excess, specifically discussing giantism and acromegaly. Now, giantism is a rare disorder in the United States, and it occurs approximately in one series in 2,367 children and adolescents with a prevalence rate of about 0.6%. It affects primarily pubertal children. Equal distribution between boys and girls are affected by this disorder. It's associated many times with pituitary adenomas, and individuals may also present with hyperprolactinemia. There are other causes, though, of giantism, and they include familial or sporadic genetic defects resulting in hypersecretion of the growth hormone, leading to giantism. It also may be associated with conditions including neurofibromatosis or even tuberous sclerosis. Now, acromegaly is also due to growth hormone secretion excess, except this happens or occurs after puberty and when the epiphyseal plate fusion has already taken place. Now, the hallmark features include a gradual enlargement of feet, a gradual enlargement of the hands, and the facial features. The incidence is about 3 to 4 per million each year, with a prevalence of about 60 per million in population. And the mean age at presentation is at about 44 years of age. No differences in race, ethnicity, or sex, and may be associated with other conditions, including hyperprolactinemia, multiple endocrine neoplasia syndromes, including pituitary adenoma, and patients are at a very high risk of developing other malignancies, including thyroid cancer. Subjective findings: patients may note changes in vision and visual deficit, and in those patients, you want to quickly rule out any evidence of pituitary neoplasia that could be potentially causing their visual deficits. There's also an observation over time where the patient complains of weight gain, increased hand size, a need for increased shoe size or ring size. And they will also begin to notice a change in their facial features, skin texture. They start to notice a heat intolerance and excessive sweating that goes along with that. They'll complain of being lethargic, having generalized weakness, diffuse arthralgias, or even shortness of breath. Frequently will complain of headaches. In women, there'll be changes in menstrual cycle, decreased libido, and in men, erectile dysfunction and galactorrhea. There's frequent sleep apnea that's found in these patients. Their partners may complain of the patient snoring, and there may even be evidence of narcolepsy, very frequently seen in this patient population. Objective findings, including generally these patients are found to be hypertensive. They have very coarse facial features, tall stature, mild to moderate obesity, and macroencephaly. So if you look at this cartoon over here, you have overgrowth of all tissues. And so you have the protruding or the prominent forehead with frontal bossing. You have arthritis, very large nose, large hands, feet, large tongue, and even the lips can become very enlarged as well. Cardiac features, including the presence of a murmur and or an arrhythmia, and multiple neurological deficits, including papilledema, visual field deficits, diplopia, and other cranial nerves 3, 4, and 6 deficits. Diagnostic workup should include radiological imaging to rule out any evidence of a mass, including a skull X-ray, CT scan of the head with and without contrast, MRI of brain with and without gadolinium. And if you are highly suspicious of a pituitary adenoma or pituitary neoplasia, you're going to want to order that MRI with thin cuts through the pituitary gland, and that will give you better visualization of the gland, and if there's any potential for any microadenoma that could be the cause of it, of the giantism or acromegaly. Medical surgical interventions, well, in those patients found to have pituitary neoplasia, transsphenoidal surgery. Medications can include long-acting dopamine agonists such as cabergoline or bromocriptine, somatostatin analogs such as acreotide, which is given at 50 to 100 micrograms sub-Q or IV 3 times a day, and you want to titrate the drug to a serum growth hormone of less than 5. And there are growth hormone receptor agonists such as pegvisomant, which is given 10 to 30 milligrams sub-Q daily, and this is based on the patient's IGF-1 levels. So I just wanted to show you some imaging. This is an MRI, again, thin cuts that were performed. This is, so here you have the lateral ventricles, you have the pituitary gland sitting right here. And of course, in these patients here, this is what would be considered to be a macroadenoma. And I can't imagine that this individual with this MRI wouldn't have not only multiple hormonal dyscrasias, but is also probably, because of the optic apparatus that is sitting in close proximity to the pituitary gland, probably having some visual deficit problems. Now, this lecture is not specific to pituitary tumors, but there are secreting and non-secreting pituitary tumors. And sometimes in those pituitary adenomas that are non-secreting tumors, they will not have any pituitary hormonal imbalances, but rather these patients will present with a lot of visual field deficits, most likely by temporal hemianopsia, because of the location of the chiasm that sits right below the pituitary, above the pituitary gland. So we've discussed now both diseases and presentations of patients who present with anterior lobe pituitary dysfunction. We're now going to shift the presentation to those patients presenting with Addison's disease and Cushing syndrome. So we'll first focus on Addison's disease. Well, Addison's disease is due to a failure of the adrenal cortex to produce and synthesize sufficient amounts of glucocorticoid hormones. So again, we are still talking about disorders involving the anterior pituitary lobe of the pituitary gland. There are 2 types of Addison's disease. There's a primary Addison's disease and a secondary. The primary adrenal is more of an insufficiency, and it's also known as Addisonian crisis. And there are many causes, including autoimmune processes, idiopathic, infectious processes, including adrenal tuberculosis, toxoplasmosis, histoplasmosis, and HIV. Secondary adrenal insufficiency is also known as an acute adrenal crisis. And in these individuals, there are multiple causes, but usually it's because of a rapid or abrupt discontinuation of exogenous steroids. The patient may have undergone an adrenalectomy, may have had an adrenal hemorrhage or necrosis, pituitary surgery, or pituitary trauma, and as I've mentioned previously, radiation. Epidemiology in individuals with primary Addison's disease, it affects about 93 to 140 per million worldwide. and about 4.7 to 6.2 per million in the white population. So there is more, this is highly seen more so in the Caucasian population than in other populations or other races. Secondary affects about 150 to 280 per million worldwide, and it's more common than the primary Addison's disease because of use of exogenous corticosteroids. Women do tend to be affected more than men, and it usually will present itself between the third and the fifth decade of life. Now, in reviewing the pathophysiology of Addison's disease, it brings us to the discussion specifically of the hormones, their normal function, and then dysfunction. But overall, Addison's disease, whether it be primary or secondary, is due to hypofunction of the adrenal gland, leading to decreased secretion of vital hormones. We can break the hormones into three: cortical hormones, medullary hormones, and adrenal androgens. Now, cortical hormones, the two specifics are glucocorticoids, also known as cortisol, which is responsible for carbohydrate, protein, and lipid metabolism and anti-inflammatory properties. When not produced, it leads to hypoglycemia. Mineralocorticoids, also known as aldosterone, are responsible for renin-angiotensin mechanism and increased sodium absorption and potassium excretion. When there is insufficiencies, there's loss of sodium and water, leading to hypovolemia and dehydration. Medullary hormones include epinephrine and norepinephrine and are responsible for our fight or flight response and are insulin antagonists. And finally, adrenal androgens. Their responsibility, specifically in women, is the development of secondary sex characteristics. When non-functioning or hyposecreted, there is a lack of libido and loss of both axillary and pubic hair. Patients presenting with Addison's disease or Addisonian in primary, there's usually fatigue, lethargy. They'll complain of muscle weakness, decreased libido, anorexia with associated weight loss, nausea and vomiting, and even abdominal pain. In those individuals presenting with acute or secondary Addison's disease, they may present as being confused, agitated, symptoms of hypoglycemia, symptoms of circulatory collapse. Objective findings, signs, as I've mentioned, signs of circulatory collapse, including hypotension and hypovolemia. They on CMP may be found to be hypoglycemic, hyponatremic, and hyperkalemic. There's usually an associated weight loss, increased pigmentation of the skin, and these are all objective findings in this patient population. Diagnostics, you're going to want to arrange for serum cortisol levels, specifically the early AM cortisol level, which needs to be drawn between 6 and 9 AM. And you're going to also want to arrange for serum sodium and potassium levels, as well as a 24-hour urine cortisol excretion and an ACTH stimulation test. And of course, you're going to want to arrange for an endocrine consult. So basically, with Addison's disease, the adrenal glands are not producing sufficient steroid hormones. The adrenal crisis, you're going to want to look for fever, syncope, convulsions, hypoglycemia, hyponatremia, severe vomiting, and diarrhea. There is hyperpigmentation of the skin. They have low blood pressure, weakness, and weight loss. And in the GI tract, as I've mentioned, nausea, diarrhea, vomiting, constipation, and abdominal pain. And frequently, these patients also are found to have vitiligo. Medical management in patients with acute adrenal insufficiency. This includes replenishment of fluid volume, correction of hypoglycemia, hyponatremia, and hyperkalemia if all present. You want to give a stress dose of hydrocortisone, 100 milligrams IV Q8 hour, and a maintenance dose of hydrocortisone, glucocorticoid replacement. The dosage is between 12 and 25 milligrams per meter square per day, or you can give them fludrocortisone, which is a mineral corticoid replacement, 0.05 to 0.3 milligrams orally once daily. Many of the endocrinologists that I work with prefer the hydrocortisone. We have had 2 patients now who have had prolonged exposure to dexamethasone because of their brain tumors, and both developed what I label as iatrogenic or acquired Addison's disease. And we had first to wean them off of their dexamethasone, arrange for the stimulation test. Both were found to have a confirmed diagnosis of Addison's disease and are now on long-term hydrocortisone. In those folks with primary adrenal insufficiency, maintenance is with hydrocortisone, same dosage as mentioned above, or the choice can be with a fludrocortisone at the same exact dose. These patients will require frequent monitoring, and adjustments will then need to be made. In women, they will also need to be placed on androgen replacement, 20 to 50 milligrams on a daily basis. Complications of acute adrenal insufficiency. This is a life-threatening event if not recognized and managed emergently. It occurs in individuals with Addison's disease who experience trauma, any type of physiological stress. The signs and symptoms I've already reviewed, but they're dehydration, hypotension, hypoglycemia, hyponatremia, hyperkalemia, and abdominal pain. Many of these patients, it's a slow, insidious presentation. They may also have some confusion, lethargy. And if they're found with that and coupled with the hypotension and the hypovolemia, there should be a high suspicion raised about them being in acute adrenal insufficiency, especially, of course, if they've already had a diagnosis of Addison's disease. Treatment is you want to fluid resuscitate them with normal saline to reverse the hypovolemia. And you want to either give them dexamethasone or prednisone to reverse the glucocorticoid deficiency. A physiological stress dose is given anywhere from 200 to 300 milligrams of hydrocortisone daily thereafter. Now, Cushing syndrome is due to prolonged multi-organ exposure to free circulating glucocorticoids. So this is the complete opposite of our patients with Addison's disease. And again, we have 2 types. We have a primary Cushing syndrome and a secondary Cushing syndrome. Primary Cushing syndrome is usually due to tumors arising from the adrenal cortex, such as adenomas or carcinomas. The secondary Cushing syndrome is due to excessive cortisol production from the adrenal hyperplasia due to excessive corticotropin production from either the pituitary gland, such as in basophil adenomas or chromophobic adenomas, or outside the pituitary gland, including oat cell carcinoma of the lung or pancreatic islet cell carcinoma. And the third category is iatrogenic Cushing syndrome, which is generally secondary to long-term exogenous glucocorticoid exposure. Epidemiology, it's usually seen in more women than men, and it can occur in the 2nd to 4th decade of life in women. And here are some of the classic findings of what you would see on objective findings, which we'll be reviewing. So in looking at the pathophysiology, again, this is due to an excessive cortisol production. And what occurs is a glucogenesis and glucogenolysis due to excessive production of circulating blood glucose. There is then an increased catabolism of protein, followed by a fat metabolism alteration. And the normal inflammatory responses of the body begin to diminish. There's abnormal secretion of both serum sodium with associated water retention. Androgen secretion increases, and the individual is observed to have altered emotional responses. Subjective findings may include complaints of generalized weakness secondary to muscle atrophy, complaints of decreased or diminished sex drive, changes in menstrual cycle, emotional liability, and complaints of fatigue. And frequently they can present with infections as well. Objective findings, including thinning of the scalp hair in women, and the women may be found to have hirsutism, evidence of hyperglycemia, muscle atrophy, wasting, evidence of osteoporosis with frequent physiological fractures. Hypokalemia may result in cardiac arrhythmia and renal disorders. Physical features may include a moon-shaped face, increased dorsal cervical fat pad, giving a buffalo hump appearance. Limbs may be disproportionately thinner than the torso. And skin changes, including the development of abdominal and breast striae, acne on the face and on the back, and decreased cognition. So here is that cartoon once again. So you have the fat buffalo hump, the striae on the abdomen and even on the breast. And if you look at the abdomen in the back and compare to the extremities, you have very, very thin arms, thin skin with frequent bruising. There's extra face and body hair, ready red cheeks, and that moon shape appearance that's classically seen with patients with Cushing syndrome. Diagnostic workup is going to include assess for hypercortisolism, which may be elevated in the salivary, serum, and urine cortisol levels. You want to assess for serum ACTH levels, serum electrolytes, including glucose. You may want to perform a dexamethasone suppression test, abdominal imaging to rule out any adrenal mass, MRI imaging of the brain to rule out any pituitary mass. In those patients found to have pituitary neoplasia, transsphenoidal hypophysiectomy may be in order. Those individuals found to have any type of adrenal mass will undergo an adrenalectomy. In those patients who transsphenoidal hypophysiectomy is not appropriate, they may undergo radiation therapy in lieu of surgery. And they are usually placed on medications that will inhibit the adrenocorticotropic hormone secretion or antagonize glucocorticoid action. I wish to thank you for attending today's session, and I hope you found this session very helpful. Thank you.